introduce these two people because I consider them both great friends of mine, and I'm truly in admiration and in awe of their work. Tom Kean is the CEO of Sea Change, and I'm so proud to be a member of Sea Change. And Linda House, oncology nurse and executive vice president of external affairs for the cancer support community. And also Linda is the co-chair of the Value in Cancer Care Guidance in Cancer subcommittee that deals with the very subject that we're going to talk about now, and that is palliative and hospice care, quality at every stage. And I'm very excited that we could bring a palliative care session into this discussion. I think all of us understand the importance of redefining what is palliative care, and that palliative care must become part of the discussion as the cancer continuum from the time of diagnosis, not at the end stage of a disease, because we're talking about quality cancer care and quality of life. And with that, I introduce Tom Kean and Linda House.
Good afternoon, everybody, and thanks for the opportunity to be here today. I think this particular session, we're excited about doing it because I know that all of us, each one of us in this room, has a very important interest in what actually happens to the people who have cancer. Everybody I heard talking today, while they were talking about different elements of the system and different ways in which they provide care to patients, etc. But at the end of the day, it was always all about the patient, and I think that's very consistent with where we are. I'm reminded of the fact I turned 65 this year, which I guess means I'm now officially at risk for cancer, as opposed to before when I was sort of at risk for cancer. But I have a lot of colleagues now who are undergoing this. One of them is a dear friend in the Sea Change community, who's one of our board members. I have a very close friend and colleague who's undergoing cancer right now. I have two cousins undergoing cancer therapy now, and I have a brother who was just diagnosed 2 weeks ago with a metastatic kidney cancer. So at the end of the day, I just want to be sure that part of the purpose of our being here, and part of the reason these two issues that we're going to talk with you about today are so important, is because we have this vested interest in the human side of what happens to people. And these folks who get cancer are looking for the very best from each of us, both individually and I believe collectively. And the more that we find our way to collective action, the stronger in the end that we will be about this. So my first disclaimer is Linda is a provider by training. I am not a provider. It's never been my side of the equation, but I have been in the cancer field for 38 years now, and have seen a great revolution, but I see us also on the verge of another revolution. We're going to talk a little bit today. We have both the cancer support community and the Sea Change logos on our slides. This is one of 6 Sea Change initiatives, and Betsy was talking about one of our other ones, but I would invite you at some point if you're interested to learn more about the other things that we're doing. I appreciate very much what I heard today about what happens at the practice level. It's not often that we have a chance to hear people on the front lines talking about these kinds of issues that they're facing, and they are significant, and I learned a great deal this morning from each of you, and I appreciate your work and the things that you do for cancer patients every single day. A couple of things I want to reflect on before we dive into this, because they do relate to our mission this afternoon. Dr. Eagle started out the morning and he said 3 things that caught my attention. The first one is change is coming. And several of us were sort of joking at the back, change is already here, but change is coming, and we know big change is coming. We have an unsustainable healthcare system the way it is, costs are out of control, and we know we're going to have to respond to those things. So change is definitely going to be a part of who we are. And the idea of being nimble through that change and always keeping our eye on the patient is important. As a part of that, the second thing he said that was important was the need to expand the conversation between patients and providers. And that's at the heart of what we're going to talk about this afternoon. And then the last thing that he mentioned is patients have to have the strongest voice, and that too is a part of what we think very strongly about. So we're going to take a little bit of a step back because we want to back up to this notion of palliative hospice care, talk about it a little more at an abstract level, and because this is a conference about advocacy, we want to talk about some advocacy opportunities that we all have to get engaged in this. And so as I think about this, and as I was thinking about it while I was listening to folks today, part of this is about marrying the concepts of patients, practitioners, which Dr. Eagle mentioned, but then also with policy. And to that end, I want to make a comment that was made by another speaker, and I apologize for not remembering which one, but somebody had on their slides this notion of unintended consequences of legislation. We have a lot of legislation that people are proposing. We have a lot of legislation that people are opposing. And the point is that we will always have unintended consequences of these things. The trick is for us to anticipate as much of that as we can and mitigate it. And the other side of the coin is when we don't anticipate it, we have to be nimble about correcting it and not spend years doing this stuff. And for those of you who want to know more about the unintended consequences of legislation, there was a book out from many years ago called Death of Common Sense. I highly recommend it. Philip Roth wrote that book. So let's go get into our, here we go, our thing very quickly here. So what we want to do today is spend a few minutes of time talking about palliative and hospice care. We are going to spend a little definitional time, but not much. And I apologize for those of you who are well steeped in this, but I want to be sure we're on the same page. What do we know about current use of these two interventions? What's important to patients? What do they care about? What do patients want? And what can we do, we, a collection of a community interested in cancer, what can we do about improving utilization and quality of services? So we came at this from a very different angle. One of the concerns that we had is that in all discussion around health reform, the whole concept of value for what we spend our dollars on disappeared in favor of cost containment. Everything came about cost containment. So what we're really primarily interested in is what about the value side? When we do spend money, what do we get for that? And how does that look for us? And so this idea of value has been rattling around for quite some time, and we decided to start having some conversations within our membership about that. Obviously, when you talk about value, we have different interpretations based on where we sit. And the IOM study that was done a number of years ago pointed that out quite extensively. If you're a patient, you have one idea what value is. If you have a provider, you have another. If you're a payer, you have another, and so on. And so the question is, how can we work on these things, and how can we increase and improve value? And our goal is always within sea changes to look for consensus opportunities for better value. And just to illustrate that, the way we went is to get away from trying to define value, since it's so eclectic, and instead ask the question, are there things that we have consensus on which are low value, which we should essentially stop doing or discourage, and are there things that we could reach consensus on that are high value and that we should encourage more? And I'm actually fairly gratified that what came out of this immediately in our discussions almost was this notion that, well, one problem we have is that we do have cancer patients suffering needlessly from pain and other symptoms and during active treatment and at the end of life. And if that's the starting place, the question came, well, what can we do that's related to value then? And we quickly went to the notion that there are two high-value, underutilized therapies, and that includes palliative care and hospice care. So just to be on the same page, and I will say that there are a lot of organizations working on these issues. We tend to use different terms to describe these things along the way. But at the end of the day, most of us have common goals. I'm going to tell you how we're talking about them, and then you can add yours to the mix as well. But palliative care is essentially for us specialized medical care for people with serious illness. And it includes a team approach to the concept of how we manage this specialized care. It's about symptom management. It's about pain relief. It's about psychosocial care, and I want to take both those words apart. It's about the emotional piece of what people experience. It's also about the social consequences of the diseases that we face, and these are significant. And not on this chart, but one other that's very important and usually mentioned in this context is the spiritual needs that people have. At the end of the day, our goal here is to make sure that people suffer the least amount of distress that they possibly can as they go through the cancer experience. Now, we do know from studies, and you'll hear a little bit more about this in a few minutes, that providing high-quality palliative care throughout a patient's treatment does reduce needless suffering. It certainly improves quality of life. It actually can improve length of life, at least from a couple of studies, and it results in lower costs. And there's a reason why that occurs, and we're going to talk more about that as well. Now, in hospice care, we're talking about comprehensive support for people with terminal illness and those that have progressed to the point that they're beyond an expectation of cure. Once again, you see the words team approach here, and we mentioned some of these folks, some of which were mentioned by Betsy in her presentation as well. And then we also talk about, on the right-hand side of this slide, the most important piece of this, which is patient-centeredness. Now, just going to give you a little bit more on hospice care, sorry. So employing hospice care, again, if we think about this, we're talking about improving quality again. We're talking about reducing suffering, and by quality, we mean quality of life. We're talking about decreasing futile care. We're talking about death that can occur at home where, for most Americans, that's a preferred place to die. There are some disparities here that we'll talk about perhaps a little bit later. And then we're talking about support for families as we go through this. So just a couple of quick facts just to throw on the table as a part of what people are experiencing. So somewhere between 6 and 20%, depending on the studies, of individuals with cancer receive chemotherapy from within 14 days of death. The argument can be made perhaps that those are not, that treatment at that point or stage of where those patients are is not going to lead anywhere. Nearly 40% of 5-year survivors report pain. That's a very large number, but 60 to 85% of patients with advanced cancer report pain. So we have a lot of uncontrolled cancer going on, and you'll notice in the next fact there that 26% of unscheduled hospital admissions are due to uncontrolled pain. These are things we, in theory, have the opportunity to control. 1/3 of hospice stays, shifting to the other side of the spectrum on the hospice side, 1/3 of hospice stays are 3 days or fewer. That is not sufficient time for people to actually benefit from the services that hospice provides so well. And the median length of stay in hospice is 3 weeks. That too is insufficient, and median in this case, as we all know, median, unlike average, means that half the people get more than 3 weeks, half the people are getting less than 3 weeks. 10% of patients are enrolling in the last 24 hours of life. Those are not numbers that are sufficient to achieve the full benefit of this care. Now, Linda and I are also going to tag team like our colleagues from the nursing community today, and it's all yours.
Thank you. Tom's a hard act to follow, but I'm going to try to add a few comments about my clinical role. You know, it's been a while since I've been a practitioner, but in my heart I will always be a practitioner. And the last clinical role that I had was as a home hospice nurse, and it's probably the role that I've been most proud of throughout my 30-year career. Most recently, though, I ran a cancer program, and one of the things that we put in place is a pretty strong palliative care program, especially for community-based hospitals. So I'd like to just share a little bit with you through those lenses, if you'll allow me to do that. So the reality, and these are 3 bullet points. I don't know if you had a chance to read Jen Temmel's article in the New England Journal of Medicine about 18 months ago, but if you haven't, I'd really strongly encourage you to read that. And rather than giving you the statistics behind it, this is what you need to remember that came out of that study and is generally true across the board. Integrating supportive care, palliative care, whatever you'd like to call it, integrative care, into comprehensive quality cancer care does these 3 things. Better quality of life. I'd like to add dignity to that, preserving a level of dignity. Actually, fewer patients had depressive symptoms as they were going through this, and longer median survival in her particular study. One thing I like to challenge myself and others is, are we keeping the patient as the true north? So as we're making decisions, as we're having conversations, as we're doing education, are we keeping our patient as the true north? So as you are reaching out into your communities and you're thinking about what is your position on this issue or how you might help us communicate, I'd really challenge you to see these words as you're making decisions, and how do we keep the patient in the true north? How do we keep the patient as the true north in whatever decision that you decide to make? So just quickly in summary, no one wants to suffer, and no one should have to. We have the tools to integrate. And one of the things that I really challenge us to think about. And when we designed our program, what we did is we integrated, well, number one, we changed the name palliative care to supportive care. And what we did is we integrated supportive care at the point of diagnosis. So we had a patient experience model that was scripted. We communicated by that model. Our team was designed, and their job accountabilities were governed by that model. But you would take a situation where the patient's presenting symptom was pain. That's a perfect place to integrate the supportive care team. So patients presenting symptom is pain. They see the supportive care team. Perhaps after some of their treatments, the pain goes away, supportive care team leaves. Supportive care team comes back in if they need to. So now this is a known entity. So just think about that. And another thing that Tom and I talked about last week was I had the opportunity to meet a gentleman at Memorial Sloan Kettering last week. And while not a part of the typical definition, if you will, of palliative or supportive care, but this gentleman specializes in dermatologic issues of patients undergoing cancer therapy, regardless of where they are in their stage. So that, again, I think is a part of the supportive care team. So I just challenge you to think about, no one wants to suffer, no one should have to. We've got tools both in the traditional sense and in the non-traditional sense if we just look around and be willing to open our minds and embrace those. So specialized palliative care and hospice care, again, can greatly increase the quality of life and also preserve a patient's dignity. And I'd like to continue to throw that. So this is a nice quote, I think, that goes with the theme of the program here today. The good physician, and I would say the good healthcare professional, treats the disease. The great physician treats the patient who has the disease. And it goes back to the adage of the patient saying, I am not my cancer. I'm a patient, I'm a person with the tumor, and help treat the person with the tumor. So I do think that it's important for us to say, well, why isn't palliative care and hospice care widely integrated? And I just wanted to jot down a couple of the barriers to use, because I think we need to be mindful of them. When you think about creating solutions, it's how do you stay mindful to some of the barriers to enable you to do that? So there continues to be a communication barrier between the patients, the families, and the healthcare professionals, whether it be doctors or nurses or whomever. And how do we continue to create tools? How do we continue to remove those barriers so that the patient feels comfortable having that conversation with the physician, and the physician feels comfortable having that conversation with the patient? And I'm not going to go into all the emotional stuff, but you can imagine and it's well documented, physicians feel like they might be letting the patients down, patients feel like they might be letting the physician down. There's a lot wrapped up into that. So that's something that we really need to work on, and one of our subcommittees is actively looking at this communication issue and building tools that would be effective in managing through that. In today's environment, we have incentive structure issues. So unfortunately, palliative care, the payment for palliative care is not reimbursed at the level that acute care therapy is reimbursed. And so that creates some level of angst, if you will, from the employer or the palliative care team, right? Because they may or may not be getting at least the hard dollars back that they're investing in it, although certainly there's a lot of documentation that would show that patients do better. There's less hospital readmissions. They can manage some of the symptoms in the outpatient setting versus having them come in through the emergency room, that sort of thing. But in today's environment, that's a very real issue, is this incentive structure. This whole sense of failure, again, that I mentioned to you earlier. And then how do you have this broad system integration? So, typically there are times when patients are, seeing this person and then this person and then this person, and there may not be that seamless integration and this, warm transfer, if you will. And one of the things that I challenged my team when I was at the hospital was, how do you think about taking the patient, handing the patient off, right? So that it's a nice warm receipt and a nice warm handoff. And in today's environment, some places we have that seamless integration, and some places we don't. I would say especially in the community setting, which is what we're talking about here today, we have some room to grow. And so again, just some of the goals for our group, and I would ask for your support in delivering these, is we want increased use of specialized palliative care throughout treatment. And again, to Tom's point, whatever we call that, supportive care, advanced illness management, whatever that is, how do we increase that service to that group of patients over the continuum? How do we make sure that we have an increased number of patients accessing hospice? How do we create hospice and the concept of hospice as something that's positive instead of the negative. And frankly, I think we're getting there. I think we're making great strides over the last couple of years to get there. And then most importantly, how do we increase the length of stay in which patients are enrolled in hospice? And for those of you who are associated with an organization, I can tell you for our cancer accreditation, I implemented this as our quality standard. So I wanted to know how many patients received a palliative care consult, what was the length of stay in hospice, how many days prior to their death did they receive either chemotherapy or radiation therapy, so that we could actively trend that and see if we can have an impact early into the curve of that. So for those of you who are engaged in institutions, I challenge you to think about ways that you can implement some level of study and put some evidence behind the decisions you make relative to that. I'm going to hand it off to you.
So I'm going to start out by apologizing to the photographer and to Linda. I made the mistake of exiting stage left where there's nowhere to go. So I thought I was being sneaky about standing back here behind you and noticed the photographer was trying to take pictures. We now have a lot of good pictures together. However, I will exit the other way next time so you get some more shots. How's that? So there are a couple of underlying issues when we talk about affecting change here, and I just want to put a few of them on the table here. One of the first ones is that there has been a certain tendency to make palliative care and hospice care synonymous in our language for a good bit of time. When you look at what our goals actually are with palliative care, we want to see palliative care begin at the time of diagnosis and carry throughout the course of the disease, whether the person is cured or ultimately winds up dying from the disease. And then hospice care, as I mentioned a few moments ago, is when we reach the point where essentially we think there's a very little likelihood of actual cure. This problem of language is important because in the mindsets of many people, if you say we want to refer you to a palliative care program or palliative care specialist or get you a palliative care consult, we wind up essentially telling somebody we're writing you off because they think we're sending them to hospice. And this may be well, yeah, I think you can get the idea. This is not necessarily the right way to start this. So as we begin having these conversations, we have to think about how we communicate to patients what we're really talking about at a particular point in time in encountering them. So this idea that these two things are synonymous, they certainly overlap because palliative care is an important part of hospice care, but they are also distinct in where they begin in the process. The second one that I want to mention, and is perhaps more foundational to how we get the population as a whole to understand, not just for cancer, but for all of us. And I'll start with a little cartoon my mother used to have on her refrigerator prior to her death. It says, God put me on this earth to accomplish a certain number of things. And then the next line says, right now I'm so far behind, I'm never going to die. And I think, you know, it used to be I always thought that was funny, and now I'm beginning to understand there's a philosophy behind it for us as a country. We have this mindset that we're never going to die as a people. And this idea we've got to get rid of. It leads to silliness in conversations. It doesn't allow us sometimes to have the adult conversations we need to have around these issues of death and dying. I'm talking now at the other end of the spectrum, the hospice end. And yet these are really foundational discussions that people have to have because ultimately we are really all going to die. So the question is how you have those. And I just want to give you one example. I have a friend who's undergoing cancer treatment now, and I'm being very supportive of that person going through this. It's a member of our church, somebody I care about very deeply. And she's made some decisions, which are, I think, well-informed decisions about continuing cancer therapy. And we were having a conversation around my household where my 4 grandkids are often to be found. They were all there that day. And their ages 14 to 21, by the way. These are not toddlers I'm having conversation with. And my wife said to me, what do you think about what she's doing? Well, I'm not a clinician. I don't have the clinical judgment that went into what that was going on. But I said, you know, if that was me, I'm not sure I'd get treated. And my 17-year-old granddaughter reacted rather vehemently. She said, that's nonsense. She said, you should be treated, etc. And you know, you need to keep going and all that. And I said, well, wait a minute. But it led to a healthy conversation within our family about what it means to confront serious illness. Now, granted, she's 17. She's never going to die for sure. That's in her mind. But my point is, I was 17 once too. My point was, I think that the way we start having these conversations within families as a community within our national discourse. And the more we can avoid silly conversations around things like death panels and stuff like that, the better off we're going to be. But we have to start having the conversations, and they have to be adult conversations. So along those lines, we have begun thinking about, well, how do you move this idea forward? It's very clear you have to move the profession. Another major partner in this, in fact, C-Change and ASCO are co-sponsoring this, but another major partner is ASCO. They certainly have taken up the gauntlet with, look, how are we going to help our physicians do this? This is not something clearly from what we've heard from the oncology community. These are not comfortable conversations. They're difficult. Maybe they're not the best person to have some of this. Maybe they are for other pieces. But the profession's obviously got to be moved in some direction here, as do the other professions who interact with patients, and others like ONS and others are in fact taking these issues up as well. We also have to create capacity. The fact of the matter is right now that we don't have enough palliative care specialists in this country who can actually provide the palliative care services. If we were to create the demand that in theory we think it does exist and will continue to grow. So I think it's very important as we think about this issue to understand that we've got to move a lot of pieces in order to make this real as we move down the line. So I want to just mention a few opportunities to improve quality and increase value. One of those is around engaging in advocacy. That's part of why we're here today. Others talking about a national public conversation, and lastly, to provide some guidance for others out there. So in terms of advocacy, part of our advocacy agenda, this is a piece of what we are talking about, is advocating for the use of palliative care and hospice care services at appropriate points. Obviously, we need to do some advocacy. This is perhaps more organizational advocacy. We also want to advocate for the use of active treatment, if desired, through hospice. Now, one of the core elements of this, and Linda mentioned it, is this notion of having conversations with patients, with families, and with providers together, all deciding and understanding where we are. And part of this may be that we have to think about, well, is there an opportunity, since hope is a large part of what we do, is there an opportunity to think about continuing active treatment, even though someone may start engaging in hospice services? And quite frankly, you can't do that now. At least if you're a Medicare patient, you can't do that now. A third area is one that was mentioned a number of times today around the issue of people being reimbursed for their time. But we need to advocate for reimbursement structures and reimbursement incentives that allow for conversations around advanced care planning to take place. And then lastly, I heard two different presentations 2 weeks ago. I'm not sure which to believe, but both are bad, around the idea of our research agenda around quality of life, particularly around palliative care and hospice care. The two different talks gave two different figures. One said that only 0.01%, that's 0.01 of 1%, of the research budget at the NCI is spent on palliative care and hospice care. The other said 0.1%. Either way, it's a bad number. If quality of life is what we're striving for, as well as survival and better mortality outcomes, et cetera, and lower morbidity outcomes, then we ought to be having these conversations, and there ought to be some research around what that looks like and how we can improve it. And advocating for a research agenda around palliative care and hospice care is another piece of our work. We also want to talk about a national conversation. Now, interestingly enough, I am very encouraged, deeply encouraged actually, that there is more conversation about this going on now than I've ever heard before. And there are a lot of organizations who are including this in their advocacy agendas and in their educational agendas for the public. That's an awesome outcome, because about 5 years ago, you didn't hear hardly any of this. And so I'm really encouraged by that. But that means that those of us who want to get engaged in it need to get engaged in it so that we collaborate well with the others, and we're not having 40 different messages around the same things going on. So there are organizations like ACS Can, which has a legislative suite of things. CTAC is doing some work around advanced care planning. CAPC is trying to deal with the question of what does the workforce look like and how to better activate that workforce, et cetera. Those all have to be a part of the conversation. Quite frankly, I'm pleased they're all at our C-Change table as a part of this. but there are lots of others. And what's important is that we don't wind up duplicating each other's efforts. So you can look at our advocacy agenda and say, wait a minute, there are other things we should be advocating for. Yes, there are. And for example, GME accreditation dollars or GME education dollars right now can't be spent on palliative care specialization. Perhaps that's something we should advocate for. But you know what? Others in our collection of teams working on these things are already doing those. The things you saw are the things we agreed on weren't going and being advocated for. We also have to focus some attention on populations with cancer disparities. If you look at much of the recent data around palliative and hospice care that's been collected, and there have been a bunch of national surveys lately, and they're quite encouraging, I might add, in terms of what people want to hear, how they want to hear it, and none of it is ideological, which I think is really important. For example, some of those surveys show that when you separate out the experience people are having with cancer and you ask the question of, do you want these kinds of services, the answer is almost equal whether you're Republican or Democrat, which says the ideological debate is actually happening here, not out there where people are facing these things. So the problem with all of that data, though, is none of it was collected in a way that allows you to look at subgroups of our population, and in particular some of the cultures that we, the many cultures who are now becoming part of our makeup and fabric as a nation. And so one of the things we've committed to doing is to doing some of that research, which we will contribute to the other organizations who are actually leading the charge with the national conversation. That makes sense, that kind of concept of we're going to bite off a piece that right now is unmet. But I think this is terribly important because we have heard, at least anecdotally, that studies, smaller studies, are showing that in some populations, this idea of dying at home, which comes out quite strongly in most national surveys, may not be true for some of the other populations and some of the cultural populations within our society. And lastly, another area where we can do work together is in this notion of providing community guidance. There are a number of different standards out there that different professional groups have promoted for their own purposes. Some of them are broad, very broadly based standards for quality in these areas. Some of them are very specific to particular specialty groups within these areas. The question is, though, if we want more people engaging in quality, more people engaging in quality standards, somebody always has to do this for me. Thank you very much. I appreciate it. I'm a very dry throat speaker. My kids would tell you that's because I yelled at them all the time. My grandkids would tell you that's because I cheer for them all the time. Y'all know that adage that if I'd have known how much fun my grandkids are to skip the kids? Kidding. I'm kidding. I love my kids, love my grandkids. Completely. So I think this issue of quality, core quality standards is a bit of a surprise to us because many of the organizations who have standards are the ones who said, can we create a core group that as we encourage other professional groups or other advocacy groups, and et cetera, to get into this, we can all be speaking from the same page. We have to do some work at sharing lessons learned. It's a recent study that was done here in Washington, D.C., which was assessing the hospice services that are provided and palliative care services provided in the local area, but was looking very much at how the organizations were structured, budgeted, how they got their funding, et cetera, and then tying it to quality. Those are important community assessments which would help a community understand what it might be able to do better, and we need to share both the methodology for that as well as the lessons learned from it. We also need to keep talking about these issues of capacity. If we don't have full capacity, and Betsy was articulating earlier today, we don't have capacity in a lot of areas, the question is what's happening to that capacity? Are our efforts making it better or is it getting worse, et cetera? And finally, we want to be sure that we help others engage. And I will tell you right now, we would invite any of the organizations in the room that aren't already engaged in our work to consider becoming engaged. We need all of your voices at the table to make this work. And it's not just about buying into our agenda, it's about bringing your perspective to our agenda. And I've already heard from a few people today in this audience who were presenting that I want to be a part of those conversations in the future because you have perspectives that we don't have yet. So thank you very much. I'm going to turn it over to Linda to summarize for us.
So just a real quick summary. We know how to improve quality, we know how to reduce suffering, and we know how to preserve dignity, which is incredibly important. And frankly, those of you sitting in the audience know how to do this in so many different ways that you could enrich this effort for us. So to echo Tom's comments, we'd love to have you as a part of this initiative. The programs we've talked about today are extremely high value and high quality services that are poorly utilized today for a number of reasons that I went over with you. And again, we have got the power and the potential to bend this trajectory around palliative and hospice care. And then no one can argue against increasing this. We've got a fight ahead of us in demonstrating the cost savings of it. It's something I know that we're all up to the challenge. I always like to tell my girls, and I'm still in the throes of raising the kids, but I like to tell my girls it's no hill for a climber. So I'm pretty certain we can get some of this information and be pretty impactful with it, but we need all of your help. So what can you do? If you are a patient, you can help us tell this story. So if you're a patient, if you're a family member, if you've had a good experience, if you've had a bad experience that we can learn from, help us tell this story and be verbal about it to help bend the cost curve, the experience curve. If you're a healthcare professional, think about how this impacts your own practice. Are you hesitant to hand a patient over? Are you overworked as a palliative care provider? What are those issues that are preventing some of this care from being delivered or throwing up those barriers that we need to think about and move through? If you're an advocate, how can you join us and help us bring all of these pieces together and then communicate? As you've heard today, the patient voice is so strong, especially when we're going to go to Capitol Hill and ask for some pretty significant changes moving forward, so we could really use your networks and your voices in making that happen.